Welcome to the August NASMHPD Meet Me Call. Today we are honored to have the distinguished authors of the 2024 TAC paper, Crisis Services, Optimizing Medication Use in Pharmacy Resources. This paper addresses the use of medications and the role of pharmacy services in helping care providers, funders, and planners better meet the needs of individuals served by crisis services. We would like to welcome Dr. Chuck Browning, who serves as the Chief Medical Officer for Recovery Innovations and the Medical Director of Behavioral Health Link. Dr. Browning has held leadership roles in both public and private care systems. Dr. Ray Love, a board-certified psychiatric pharmacist and consultant to NASMHPD. He is Professor Emeritus at the University of Maryland, Baltimore, where he directed pharmacy services for the state of Maryland psychiatric facilities for over 40 years. Dr. Robert Cotes, an associate professor and distinguished physician in the Department of Psychiatry and Behavioral Sciences at Emory University School of Medicine. He also serves as the director of the Clinical and Research Program for Psychosis at Grady Health System. This paper is part of the SAMHSA-funded 2024 Beyond Bed series, which includes 10 papers, several of which were featured at the recent NASMHPD 2024 annual meeting, and others that will be highlighted in future Meet Me calls. Thank you all for your contributions to this crucial work. Dr. Browning, please go ahead.
Thanks, Brian. And thank you so much, Brian and Megan and Dr. Pinels, Deb, for thanking us and giving us the opportunity to work on this paper. It was a pleasure to do it with Rob and Ray. Thank you so much, Victoria, for helping us pull off this webinar and the technical aspects of getting that going through. So as Brian said, this paper is about optimizing medication use and pharmacy resources and crisis services. It is really a part two of a paper that we featured and presented at last year's meeting as well, and it takes a deeper dive into some of the systemic and infrastructure pieces. And so it's a lot of the what and the how. But to start our introduction, I just wanted to go back and reemphasize the why this paper is important to us and important to us to share to you as in your role with the states. Next week. So if anyone was after everyone that was at the meeting, there was such a great emphasis on the role of 988's implementation and some of the changes and evolutions in our national guidelines that SAMHSA is working on the whole entire continuum of crisis services. Knowing that previously there was a real focus on contact and support and rescue. And so there would be anyone, anytime, anywhere. Some of the terminology has continued to evolve. We're working on standardizing definitions for the new upcoming guidelines and a discussion of the entire continuum, including preventative services, all the way through to follow-up services coming into the crisis and going towards recovery. However, when you look at this continuum, I think it's really important, and what this paper focuses on is that the system and the original guidelines, one of the biggest focuses was minimizing law enforcement, jail, and emergency department involvement in the crisis situation for folks. So I'm going to take a quick step to walk through a review of the importance of that with a graphic that I think really helps illustrate why it's so important to be able to execute these medical guidelines and have the infrastructure of optimizing the pharmacy and the medication pieces of these. Next, Victoria. So as you can see in pre-988, it was a one-way flow for most people around the country, where if you did call 911 in crisis, law enforcement is going to be the primary responder out in the community. And the pathway, if you couldn't stay at home and needed more support for most folks, was to go through an emergency department, which creates a true gauntlet. Law enforcement, it makes it a lot easier for them, instead of spending hours of wall time in the emergency department, to have people jailed on nuisance crimes. Next slide, Victoria. And then obviously the Crisis Now model that's been discussed and shared on a Crisis Now website from NASMHPD, big focus on that was following some of the concepts of the Arizona model, which for decade plus has been working towards creating a different pathway that bypassed emergency departments and gave an easy path for law enforcement when they were encountered, and or mobile teams, to have separate out-of-hospital crisis facilities for evaluation, support, treatment, stabilization, to minimize number of beds needed in acute inpatient psychiatric centers. And then finally, so in a post-988 world, one of the big outcomes of that is the goal of this whole system as it was created and set was to create a separate pathway where if you called 988 as a separate call line, you really can bypass the use of law enforcement in other than an imminent public safety threat or an emergency department other than medical emergency situations. However, if these crisis facilities that when people do need that higher level of care and they're part of the group that's probably going to be labeled in some of the terms that we've been talking about as a safe place for help, but there's something specific about them. And if they cannot manage and support higher level medical situations and things that come up, then those folks are still going to need to go through the medical emergency department, and it continues to cause a challenge in that system. Next slide, Victoria. So when optimally working and having that flow going so that you're only using emergency departments for those particular situations and you're only using law enforcement for imminent public safety concerns, this new development of the idealized 988 post 988 system truly keeps almost all crisis situations in an intercept zero on the sequential intercept model. And the system is designed to perfectly do that if you execute it that way. And then next slide, Victoria. So the final importance of this is that when you don't have that capacity in your community or in your state, and you have centers that can accept some people, that's still going to help a group of people not have to go to an emergency department or not be encountered by law enforcement. But if you don't have the ability to be able to say, you know, I can support this person's medical needs while they're with us. I can support this person who's, quote, very agitated or, quote, history of violence or, quote, too suicidal or too intoxicated. If you can't manage those things as a center like that, then what tends to happen is you do become more of a niche service that serves some people, but not everyone. And we know in those systems that, and we look at the data, when you don't do that, that everyone tends to have a disproportionate the folks with marginalized populations. So the why is that this system truly creates a zero sequential intercept focus that truly provides crisis care for everyone. And it's to me is the most functional part of a gatekeeper of helping that system flow. Next. So the previous paper that's to be released any time now was called Medical Considerations for Crisis Care. And Victoria, you can just flash those up as we go. And it basically covered the types of medications needed, thinking about how different levels of the crisis continuum needs to coordinate with emergency medical services. It talked a lot about medical clearance and medical stabilization and that being a barrier and how to manage that. There was a great focus part of that paper, I felt like, in making in talking about how to do medical things with people served in crisis in a recovery-oriented way, supported by a super strong peer support specialist who led that piece of the paper, and then finally talked about systems and tools that were needed. So to intro into Ray and Rob talking about their pieces, this current paper has kind of three major highlights. This was the actual things to execute. And then this next paper's goal that we're going to be discussing today for our upcoming paper, for the next slide, Victoria, is really helping to share these types of three things. And you can go on and pull them up on the screen. And that is, the pharmacy and licensing infrastructure. For an out-of-hospital center to be able to carry that out, Ray's going to really talk in depth about lots of different issues and nuances about that for in your state being able to execute this. Rob is going to really get into some of the specific crisis medications with some updates, but really a lens of some of the systems and trainings and tools needed to be in place to execute some of these topics. And then finally, I will follow up with a final discussion about thinking about continuous quality improvement and the systems and tools needed to carry all this out and pull it together. Right?
Thanks, Dr. Browning. Next slide, please. So, hello, everybody. As you can tell by the title of this session, pharmacy services is a major theme of this paper. And the first message appears in our first recommendation. And if you read through it, what it really tells you is that consideration of pharmacy and medication use policy is a whole lot more than just where am I going to get drugs for the patients. There needs to be an awareness of the consideration of legal issues, regulatory issues, accreditation issues, licensure issues, that affect the use of medications and the plans for the facilities. And these involve everything from medication storage to medication administration, pharmacy licensure, telemedicine regulations, controlled substance issues. All of these vary from state to state. So there really needs to be a consideration of these issues. And the plan also needs to address how medications will be paid for and how they'll be billed to Medicaid or third-party payers or indigent patient funds, or even the patients themselves, depending on the structure that is set up. So you really need to start at the beginning before you engage pharmacy services to talk about the policies and the procedures and the protocols for medication use. An example might be teleprescribing. So how will teleprescribing take place if it's going to? How will it be implemented? And the plan also needs to consider the need for non-dispensing pharmacy services such as administrative services, education, and clinical consultation. I see there's somebody with a hand up. Are we going to take those now? Or are we going to get them at the end? Megan, how would you like us to do that?
We're going to have questions through the chat box at the end.
Okay.
So if you have a question, please put it in the chat box. Thanks.
All right, thank you. Next slide, please. Yeah, if you could just put up all the bullets there, thanks. So one early decision in planning for pharmacy services involves where the pharmacy will be physically located and whether it will be contractual or part of the structure of the center. So the questions that need to be decided are, will the facility operate or the center operate a pharmacy on site? Will it contract for pharmacy services? Is the center part of some sort of campus on which pharmacy services already exist? Will the facility depend on maintaining a large stock of medications and receiving deliveries from an outside entity? And what hours will pharmacy services be required? If a facility is going to, or a center is going to operate on-site pharmacies, that can be expensive. They require space and equipment and personnel and lots of administrative costs. And if you operate an in-house pharmacy and the facility assumes responsibility for billing and for procurement, that will also involve a lot of administrative support and additional resources. The nice thing about having an on-site pharmacy is that you've got complete control over the formulary and medication policies and procedures and don't need to yield to accommodating some sort of a vendor. And the most important thing is that there's immediate access to medication, and there's immediate access to the unique contributions that an on-site pharmacist can furnish. If the choice is an off-site pharmacy, then you've got or a vendor pharmacy or a contract pharmacy, then you've got to negotiate that contract. And I've been involved in negotiating a number of pharmacy contracts, and there's some things that you need to pay attention to. First of all are the specifics about vendor performance, and secondly are different fees or hidden costs that can be in a pharmacy contract. And I'll give you a few examples. So what is the expected pharmacy response time when you need medication? What will be the regular delivery schedules and how will they fit with your staffing patterns? Are there additional costs and markups for stock medication, and how much are those markups? What about medications that can't be billed for some reason, either because they're not covered or they're over the counter? How will unused medications be handled, and will you be able to get reimbursement for those? And what about paying for all of those other things you need the pharmacist for administratively? Meanwhile, the center is still going to need to budget resources to monitor a contract, including managing any on-site inventory, tracking billing for non-dispensing services and not billable drugs, and assessing the quality of the services. Something that's important that I think we don't realize is that vendor pharmacies often serve multiple clients, and they may have previously established processes and schedules, and then the center has to accommodate those. So some of the things that often we run into where vendors are less flexible are the mechanisms by which orders are transmitted to the pharmacy, delivery schedules, after hour services. Sometimes the formulary can be rigid, and there may be other administrative processes that are a bit rigid. Now, I know that a lot of centers really like to go with vendors because they want to divest themselves from the complexities of medication billing. But in doing so, they often lose control of some of the choices about medication use, about formulary. And one thing that you also have to pay attention to when we use vendors is there's a greater possibility for fraud and diversion. So we have to make sure that we have processes to look out for those. There are also some costs that you need to pre-negotiate with vendors, like what if medications go unused? How will they be handled? What if medications are dropped or spilled? How will they be charged, and who's responsible for that? And what if there's, with these expensive long-acting injectables and some of the newer medications that are quite expensive, they may require preparation. Who's going to handle reimbursement if something is misprepared and becomes unusable? Those costs can be pretty substantial. Next slide. Now, there are some hybrid models. I don't know the degree to which they're used in crisis care currently, but they've been used in long-term care facilities and those sorts of models where a pharmacy is contracted, but it's contracted to operate on site. So that's always a possibility, to contract with a vendor to provide on-site services. Another hybrid model is to establish that the contract pharmacy will give you certain number of hours on site to provide some of the services beyond dispensing. And some of these services beyond dispensing include things like preparation and administration of long-acting medications, inspection of medication areas that might be required for accreditation or licensure, obtaining medication histories, providing pharmacokinetic or pharmacogenomic consultation, managing the formularies, patient and family education, staff education, coordinating compliance with some of the new regulatory issues like the FDA required REMS or prescription drug monitoring programs that the states operate. So all of these are additional services that that we need to consider. So let's move to the next slide, please. The other area we talked about in the pharmacy realm was formularies. And when we normally talk about what drugs should be on a formulary, we talk about, well, what's the clinical characteristics of the patient population that we're going to serve. We want to make sure that the drugs that we select have established efficacy and reasonable safety records, that the drugs we select have a good way of being administered that meets the needs of the patient population. More recently, over the past decade or so, cost has become a primary consideration, in formularies, as has abuse potential. Another area to consider is, where do these drugs fit on treatment algorithms and guidelines? And that becomes particularly important because we're having issues with drug shortages, and you need to make sure that you have alternatives on the formulary. You may not just have the particular drug that you want. Regulatory requirements can also become an issue in selecting drugs, and sometimes even storage requirements. Do we have adequate storage for the type of medications that we want to use? We're not going to go into the whole list of what drugs should be on a formulary for a crisis care center. When the paper comes out, there is a list, or if there's questions about that, we can try and address those then. But there are some other major considerations that when Chuck and Rob and I were talking and putting together this paper, they kind of came forth. First of all is we need to acknowledge that in the crisis center, we're going to start people on medication, but we're not going to be the ones to monitor that medication or continue to prescribe that medication. And secondly, we may be put in the position of continuing medication that someone else has prescribed. And for these reasons, we really need to think about community norms when we establish formularies. What is used in the community that the patients will have to return to? We also have to talk about what are the clinical conditions that we're going to encounter in the crisis center. For instance, if we're going to be dealing with treatment failures and perhaps treatment resistance, we may need medications that are powerful enough to deal with those patients, a drug like clozapine, for instance. Or is adherence an issue that might bring somebody in? In those cases, do we want to talk about using long-acting injectable medications? And finally, we need to make sure that when patients leave the center, they'll be able to continue to access whatever medications are prescribed. And that means, number one, that we've got to find a place for those medications to be prescribed upon discharge, and we need to communicate with those individuals who will be doing the prescribing. But we also need to make sure that the patient can afford those and that Medicaid will pay for those or whatever payer. So we need to coordinate formularies. Next slide, please. So some of the issues that we need to consider are what will Medicaid pay for? What's on their preferred drug list? Do they have a tiered drug list? And where do the medications that we want to use appear on that? We need to do the same thing for the formularies of common insurers or the pharmacy benefit managers that insurers in our area use. We need again to refer to what formulations of medication are used commonly in the community. An example of this is buprenorphine. We've had situations where a formulary was devoted to using buprenorphine tablets, and the community preferred buprenorphine film. So we need to make sure that we have formulations that will be used in the community. We need to talk about initiation or continuation of long-acting medications. Who's going to give those in the crisis center, and who will be administering those in the community? And finally, the issue of clozapine comes up because it's an underutilized and complex medication in terms of its requirements. So we need to make an upfront decision about whether the facility will start clozapine or perhaps continue or reinstitute clozapine treatment, and make sure that we have provisions for that to occur. So this has just been kind of a short survey of some of the issues to consider about pharmacy. I think it's obvious that the use of medications in crisis care and in behavioral health is becoming more and more complex. The regulatory environment is requiring more and more ongoing resources. There's new technologies being employed in behavioral health, such as pharmacogenomics and pharmacokinetic adjustment of medication levels. And I just want to emphasize that pharmacists and pharmacy services can help address a lot of these emerging issues. And I hope your takeaway is, again, is that pharmacy services are a whole lot more than just getting the medication to the patient. So at this point, I finished my section, and I'm going to pass it off to Dr. Cotes.
Great. Thank you so much, Dr. Love. It's good to be with you all. I'm kind of like the third kind of runner in the relay race, where now we're going to go really fast. And I'm going to try to go over these next 3 recommendations in about 5 minutes or so. So if we could just go to the next slide. All right. And in the 3 recommendations I'm going to discuss, we're really going to focus on evidence-based psychopharmacology, and then how do you actually implement that into the crisis care setting. And Ray pointed out 2 really important issues. One is, what is the standard of care in the community? And number 2 is, who are the patients that you're going to be working with? You really have to know both of those things very well in order to set this up. So the first thing is laboratory services. And this is really necessary in order to develop an individualized treatment plan. The laboratory services that you have access to can really kind of define the scope of what's possible and what's not possible with medication. So we're talking about things like vital signs, blood glucose, breathalyzers, urine drug screens, COVID tests, pregnancy tests. And then some crisis care facilities may actually have access to point of care absolute neutrophil count testing as well, or they may share that with other systems. So when contracting with laboratory services, some of the things we would think about is, what's the turnaround time for some of these labs? Who picks up the samples? Who's going to be there if there's abnormal results? What's the mechanism if something comes back critical? So the other thing that comes up with laboratory services, if you do have to admit somebody to the hospital might want certain labs that are drawn already, and the crisis care facility needs to know what these are and kind of get those potentially in advance to help kind of reduce the amount of time someone spends in a crisis care facility. Finally, EKGs are important to both diagnose cardiac issues at times, but also kind of look at the QTC, because many of the medicines that are used can definitely prolong the QTC. And there's some new technology that might allow you to do this without getting a full EKG these days. All right, next slide. So the laboratory services can really set you up to have access to highly effective pharmacology. And in this, I think that our recommendation is about crisis care offering clozapine and some forms of long-acting injectable antipsychotic medications. And there's a couple things to consider around both of these. The first is, is somebody already on clozapine? And then how do you know that? Has someone recently gotten an injection of a medicine? And then how do you understand that? So you have to there's a little bit of detective work that goes into this sort of on the front end. One of the things that we highlight in the paper is that crisis care services actually should have the ability to reevaluate and reassess a person's current pharmacologic regimen, and then possibly even determine a new course if needed, with consultation with the outside treaters. And this might mean, starting a new LAI, consideration of starting clozapine for someone who has mania. Maybe it's stopping the antidepressant, but it's that coordination piece that I think is really important. Another thing that we wanted to highlight here is that everyone should all the prescribers should get specific training around clozapine REMS. And one of the barriers for this might be the amount of time that people think that it takes to actually get enrolled. And it usually takes about 15 to 30 minutes. And I just put a checklist here about the things that people need to do in order to become enrolled in clozapine REMS. All right, next slide. So On the long-acting injectable front, we've put a table in here about the long-acting injectables that have been released since 2021. And there's 6 of them. And there's actually 2 long-acting injectables, antipsychotics, that have been released in 2024. And while I think that this is a really good thing, having more options, different, places these medicines can be injected and different amounts of time that they last, also it can be a little bit confusing. And I think that, crisis care facilities having an awareness of these new long-acting injectable options is very important to minimize medication errors, because sometimes you might have someone who comes in on something, a new agent on a sample, and you don't have that on the formulary, and you need to figure out how to convert that long-acting injectable to something else, or can you give it? So these are some important things to think through. Also, Ray was talking a little bit about some of the sort of storage considerations. Do you have to reconstitute it or not? In the paper, we also talk about situations like what happens if someone comes in recently getting a long-acting injectable and then they have breakthrough symptoms, and how do you prepare for that? Okay, next slide. We also recommend that in terms of medication use, it's important to think about proactive solutions to commonly encountered challenges. And some of the ones that we highlight are, what do you do with drug levels for medications, therapeutic drug monitoring, the level's too high, the level's too low? How do you retitrate clozapine? How do you start clozapine? What happens if there's an interruption in the long-acting injectable antipsychotic? How do you manage agitation? What do you do about catatonia? So having some sort of sense that you can, of these different challenges, and being able to do this proactively can be helpful. Next slide. And, one construct we raise is, if somebody's on certain medicines, can this automatically prompt a level? So you can know if the level is too low, if the level is too high, and then you are thinking about, maybe medical care instead. And then what do you need to do? And then also having the resources in your system to actually have ready access to interpreting the levels and kind of what they mean. And that sometimes takes some training. Next slide. The other thing crisis care facilities should be aware of is there's been some updated language around clozapine retitration that changed in the package insert in 2023. And they actually give a little bit more guidance about how to do this. So if somebody comes in and they've maybe missed a couple of days of clozapine, you got to think about anticholinergic withdrawal. You got to think about breakthrough symptoms. You got to think about how to restart this medication. And I think this is just one example where the proactive solutions can be important to think about. All right, and next slide. All right, and I'll turn it over to Chuck. Thanks, everybody.
Thanks, Rob. I'm going to close out real quickly before we get to questions. If you think about this, what we've given you is discussed multiple different tools or processes that can be used to help execute this mission of being able to have these kinds of services for best care. So if you look at it at a provider site who's offering these services, it's the people that you have, the processes that you do in terms of training, the tools that they have to use. And that includes also being able to have tools to measure metrics, and then having systems in place where you're regularly meeting and looking at those metrics with that idea of continuous quality improvement, minimizing waste, improving efficiency, looking for errors and correcting them and decreasing chances for harm, and continuing to work on how we serve people. But I would argue that this is not just for the people providing the service, but going back to looking at what's been happening in emergency physical healthcare over the past multiple decades since 911 came out, is it needs to be done at a systemic level, also at community level, county levels, state levels, and federal levels, so that we can continue to share what works and grow as we innovate this care in crisis spaces. And in the final slide, we did take a tool worked on by the National Council for Wellbeing's Medical Director Institute that was designed to help look at measuring metrics for outcomes from a personal impact perspective of the people using crisis services, so the mnemonic access to help with these words. And we converted it over to put a reflection towards access to help for medication pharmacy resources in that. And so as you can see, and in the paper, it'll detail lots of ways to think about having systems to measure impact. And I'll share just one quick before we close out. Since Dr. Rachel Talley's on the call, the American Association of Community Psychiatry created this tool for assessment of anti-racism tool as an organizational framework. And this can really be applied to medications and looking at different demographics related to things like clozapine access, use of forced meds, and some of those aspects to look at how we're doing that. So in a final close, really appreciate your time today, and we're looking forward to answer questions about this. It is so important that we have the access to be able to do these things, because this is what makes and breaks the difference between folks in crisis needing to go through an emergency department versus being able to be supported in a system with a care that feels like care. Thank you.
Thank you very much. This is so informative, just packed with information. I will tell you, we have a lot of questions coming in. One is, how should workforce or staffing be structured to ensure the most efficient use of prescribing in the crisis receiving centers?
You want me to cover that, guys?
I'm going to just throw it out there and then maybe get your different perspectives. What are your thoughts?
Well, I mean, we talk about this in the paper, actually, Megan, which is discussing, and again, going back at the systemic look, you need to have 24/7 nursing to be able to accomplish this in terms of assessments, and then in terms of being able to manage some of these situations and give feedback with behavioral health medical professionals or providers, whichever term you want to use for them. However, you also have a 24/7 coverage by providers to be able to give orders. Some smaller sites may do this with a combination of in-person time versus on-call time, and being able to help have the systems in place to manage those things then. And some crisis sites that are larger and funded to be able to do this have 24/7 providers on site, seeing people throughout the day, just like an emergency department. So I've seen different variations of how that goes. Without those things in place, you just truly can't manage the medical complexity that we've been discussing. And you would be what I would call maybe a lower level of care that can support some people, but can't do all of these aspects.
Okay, thank you. That's really helpful, especially as commissioners start to make decisions about, what's needed for a crisis receiving center. And the other piece, do some of your recommendations change based on the individual and the age of the individual who is needing crisis services? Like kids, older persons, youth, adults, male, female, etc.
I'll take that one, Ray. You look like you're about to.
Oh, Ray, you're on mute.
No, I'll let you deal with that one, Chuck.
Okay.
You've got more experience in that area.
So yes, I would think that's definitely true, Megan. Obviously, if you're working with children, there's going to be different dosing, potentially different guidelines and things that you're going to be working on related to medications. Whereas as you get into older population, you do have to be just like we'll talk about this in the paper, and that's one of the importance of lab values, as well as being able to have a stronger level of medical assessment, is thinking about things like people's liver and kidney function and how well it's going can impact dosing amounts that you would do as well. So it can definitely have an impact on some of the things that you will see, as well as how you might choose to go about different things. The other thing that happens just stereotypically as we deal with older population is they end up being on more and more medications for their physical health care. So you have to have training and understanding. And I think it's really helpful to have electronic systems that help warn nurses and providers about medication interactions and things of that nature. So, it adds more complexity as we build in more of those things. And for any crisis stabilization centers that are receiving people and working with them longer than for 23 hours and having like a longer stay, it's not quite a full inpatient stay for 10 days, but maybe averaging the stay of 3.5 days, you have to be able to have the infrastructure in place to manage their physical healthcare medicines to keep them safe and stable on those while you're there as well. And that's detailed in both of the papers that we've discussed today.
And Megan, if I can, I will go ahead and make one comment, and that is, the issue isn't just starting somebody on medication. it's this change in the direction of their treatment, and coordination with the next step is a big issue, and it's frequently very different when we're dealing with youth than when we are dealing with a geriatric patient. So figuring out those communication pathways, figuring out the care coordination for the next step when they leave the crisis environment is something that we do need to look at. And I think that commissioners in particular can be helpful in making sure that everybody cooperates well in that realm. By the same token, I think we need to look at the scope of the services that a center is going to be providing up front and set that, and certainly government plays a role in helping define what the scope is up front. And once that scope is decided, that helps us talk about who we need to do what, and helps us delineate what roles we need to fulfill, and who's the best individual to fulfill those roles, to get back to the previous question.
Great. Thank you. Dr. Cortez, did you want to add to that?
No, I was actually hoping to respond to Dr. Fetter's question in the chat.
Sure. I was actually just going to move to that. If you don't mind, I'm just going to read it real quick so people know. Dr. Fetter says, our crisis center faltered under the weight of state requirements, including the need for multiple long assessments at the time of intake, which were not suitable for a person in crisis. What initial intake assessments do you recommend for a person? For a person coming in primarily for a psychopharm need?
Thanks, Dr. Fetter. I think that's a great question. And in the first paper, we really focused a lot on the assessment portion of this and how to do this in a recovery-oriented way. And I think that, the multiple long assessments can really make engagement with a person and sort of feeling like care feel very difficult. And it just feels sort of kind of like an interrogation and things. So in the first paper, we talked a little bit about sort of specific assessments for specific kinds of conditions. And also, I think this idea that not everybody necessarily needs the same sort of scale that's done for the kind of main presenting problem that's happening. I also think that if just simply the communication with the outside providers can also really be quite helpful to sort of accelerate the development of what this initial assessment is. Sometimes that can go even further than the standardized assessments, is sort of calling, having somebody that's worked with someone for a long period of time, if that's possible. So it's a really big challenge, I think, trying to get this balance right. And I am optimistic that once when the new paper comes out, there'll be some specific guidance in there around which particular tools to use for which types of conditions.
And I would say, I'll totally agree with all of that, Rob. In training, when you look at that triangle of people, processes, and systems, in the training piece, there is a training specifically about how to do assessments that focus on the things that are relevant to the crisis, and not a full comprehensive exam that should not take that much time. But one other piece that's really important that we highlighted in that Access to Help acronym of that modification of the tool from the MDI is timeliness. That's what T stands for. And so having metrics that look at door time of showing up to door time to getting certain assessments done, as well as door time to orders being put in and being able to get medications for certain needs. If you have a system in place where you're tracking that and evaluating it, you will help look at doing things like workflow improvements, training to support better efficiencies, and things of that nature, which are so important because timing in crisis is really, really relevant and impactful.
Great. Thank you very much. And there is a question here. Are medications that are counterindicated for use with individuals living with dementia specifically highlighted? I think the person means in the paper.
Yeah, we don't talk a lot about dementia in this particular paper, talking about avoiding anticholinergic drugs that might be problematic. So we don't go into that a lot.
Okay. And just the last question, how many peers play a role in this process?
The process of the paper or the process of this medication workflow in crisis?
Sure. Yeah.
Both, or
Yeah, the medication flow, any kind of decisions that are needed in terms of setting up pharmacies and crisis receiving centers or crisis stabilization units.
well, I think that's going to be individualized by the organization, and also, but it can be very much influenced by the funders, the planners, the regulators about those things as well. I know at Recovery Innovations, peer support is a big part, and we do training so that peers they're not doing the assessment of response to medications or types of medications in the work that we do. That's in the subject matter expertise of nursing and the providers. However, having a general awareness and being able to talk about things that people are experiencing, being able to engage with someone and encouraging them to be open with the provider about their concerns about past experiences that didn't work well with them for medications can be just invaluable tools of engagement and increasing that liaison and partnership that would be the ideal outcome. And so I think that peer support specialists are an invaluable tool, even in that realm of this, something you would consider more in the medical healthcare side to make it work better and be more collaborative, more person-centered.
Great. Thank you, all three of you, so much for this incredible information. I feel like, 3 years of work was compacted into about 30 minutes. So thank you very much for your knowledge and your expertise. And we have your contact information here on the slide. So if anybody has any follow-up questions, please feel free to contact Dr. Browning, Dr. Cortez, or Dr. Love. Thank you very much. We are now going to transition to Aaron Walker, who is NASMHPD's Policy Director, to provide the Washington update. Go ahead, Aaron. Thank you.
Thanks, Megan. Good day to everyone. Can we go to the next slide, please, Victoria? Just make sure everyone has this on their calendar. SAMHSA's upcoming 988 Day, which will be September 8th. And this is to raise awareness of 988 activities around the country. And they also have a digital toolkit where you see the link here. And this is just a comprehensive resource designed to support the observance of the day, but also includes a variety of assets and guidelines to help partners, grantees, crisis centers, and community leaders engage their audiences and amplify the message of no judgment, just help. Next slide, please. And just make sure everyone saw that SAMHSA released the 2023 National Survey on Drug Use and Health results, the NSDA. This is also accompanied by two infographics highlighting overall findings as well as findings by race and ethnicity. The sample size was 67,679 and used multi-mode collection methods and gathering the data. Along with the results as well as the companion briefs, they can be found at the link here, and there's a link there at the bottom to learn more. Next slide, please. Just a reminder that the notice of funding opportunity for the cooperative agreements for CCBHCs is out, and the application deadline is Thursday, September 12th. The purpose of this is to support states in developing and implementing certification systems for CCBHCs, as well as establish prospective payment systems for Medicaid reimbursable behavioral health services, and to prepare an application to participate in a 4-year CCBHC demonstration program. And you see a link here at the bottom. Next slide, please. On June 23rd, CMS issued a letter to state health officials addressing the statutory requirements regarding the availability of certain state plan services for incarcerated youth in Medicaid and CHIP and modification of CHIP eligibility requirements for children who become incarcerated. This also provides guidance on the requirement that states submit a state plan amendment to implement the coverage with an effective date of no later than January 1st, 2025. And you see a link here to the letter. Next slide, please. Also, CMS on July 12th released a companion guide to the fee-for-service financial provisions of the Ensuring Access to Medicaid Services Final Rule. This provides requirements related to documentation of access to care and service payment rates. And it's also designed to help states understand when requirements apply to them and how to meet those requirements. And you see a link here at the bottom. Next slide, please. Also on July 16th, CMS released a state health official letter to provide guidance and expectations for compliance with the requiring accurate, updated, and searchable provider directories requirement. Some of the specifics look at changes to provider directory data requirements and features, availability of enhanced federal financial participation for Medicaid fee-for-service provider directory development and operations. And as far as non-compliance, corrective action plan requirements for reapproval for Medicaid systems, and then returning to compliance and requesting reapproval for Medicaid systems. You see a link here to the letter at the bottom. Next slide, please. On July 8th, SAMHSA announced notices of funding opportunities aimed at improving women's behavioral health across the United States. This is for a total of $27.5 million. And also they announced an additional nearly $1 million in grants for 2 grant recipients as part of the services program for residential treatment for pregnant and postpartum women. You see links here to the announcement. Next slide, please. Also, there's the part 2 of the upcoming webinar series, Successful Grant Writing for 988 Suicide and Crisis Lifeline Centers. The next one occurs August 27th from 1 to 2 p.m. Eastern. And this part 2 will highlight common grant writing challenges, identify key elements of successful proposals, and how to promote organizations with potential funders. And you see a link down here at the bottom to register. Next slide, please. And also the beginning of another series, the 988 Crisis Systems Response, Understanding Children, Youth, and Family Services Across the Crisis Continuum series, session 1, the foundation, will occur on September 5th beginning at noon Eastern. And this is intended to discuss the national guidelines, lay the groundwork of the current state of youth crisis services, and provide an overview of why its delivery across the crisis continuum is important. Immediately following, there will be an office hour session from 1 to 2 p.m. Eastern time, and future sessions will build on this foundation with sessions focused on the design and implementation of youth crisis services, as well as systems integration and the role of schools in delivering youth crisis care. And you see a link at the bottom to register. And I want to thank you guys. Next slide. Thank you. And I'll pass it back to you, Megan.
Great. Thank you, Aaron. I just had one question for you. Regarding the grant writing webinar, there's the one on August 8th and then the second one on August 27th. If you didn't attend the one on August 8th, is that detrimental to joining the one on August 27th?
No, but from my understanding, they're signing up on the same link for both. So I believe once you register for either one, I believe you would also get the recording for either of them.
Okay, wonderful.